What's up, you guys? This is Shay and welcome back to my channel. So today I'm going to be discussing jobs that you can have that's non-bedside as a RN. Okay, these are jobs that I have worked my own self, so I can discuss them. I won't be able to discuss all the jobs. I might have to break it down into videos, and then at the end of the video I'll let you know the other jobs that I work in. You can tell me like what you want me to discuss next, which job. So first I'm going to discuss being an RN case manager for a hospice company, as well as outpatient palliative nursing, because those are kind of like similar, different but similar. And let me just discuss this really fast, okay? Because a lot of people get palliative and hospice mixed up, okay? Palliative, that is like a holistic way of like treating a patient, right? So say for instance, if a patient has like some type of chronic disease, if a patient has cancer, a patient has heart failure and things like this, and etc. And say for instance that the patient wants to continue treatment, wants to still do preventative measures, still do things like that. That is palliative care. So what we're going to be doing is managing their symptoms. We're not going to be treating them like the doctor will still treat them, but we're going to be managing their symptoms on a holistic way. Like meaning like if they have pain, they have nausea, diarrhea, the pain medicine isn't working and they need stronger medicine. They're having side effects from their chemo. Different things like that. If they want to talk about advanced directives that they don't know about, to explain a post to them. Just think about things like, when I say holistic, I don't like to say it in a way that just treating managing their symptoms. No, we're like talking to them. Do you have like social needs? Like say for instance, do you need PT at home? It's like different, right? So I like to discuss it on that level, because sometimes people get it mixed up. Hospice is when you just want to strictly just want comfort. You do not want to you don't want to continue treatment. If you have cancer, you don't want to prolong your life. You just want to be as comfortable as possible. But let's not get it twisted, because a lot of people, I've seen a lot of people saying, oh, they on hospice, they got an infection, they don't need antibiotics. No, we're not trying to expedite their their life. If they have an infection and they need antibiotics, they can still get antibiotics. But if they're on hospice and they want to go to the hospital to be treated or admitted, they're bumped off of hospice. At that moment, they can always come back onto hospice, but they're bumped off of hospice, no longer a hospice patient, because now they're seeking treatment. I hope I was able to explain that. And if you guys have other questions, you guys can ask me, because I know that it was kind of vague what I was saying, but I like to just explain that to them. And also with hospice, you need to have 6 months or less life, time to live. That's what they like to say, but sometimes people are on hospice longer than that. So I just want to say that too. It depends on a hospice company. Sometimes even if you have 6 months, even if they give you 6 months or less to live, if you live past that 6 months, you may, depending on the company, be able to stay on hospice. Some companies kick you off on hospice, kick you off of hospice, may send you to palliative care, and may not send you to anything and just have you doing your due. So it's kind of like a fine line, but hopefully I was able to explain some of it. But I enjoy both. So for the hospice RN case manager, I really enjoyed that. Let me get something to drink. Hold on. Sorry. So for the RN case manager, I did that for about a year. I really enjoyed that, okay? So I did it part-time. So part-time, I worked like 2 or 3 days. So for those 2 or 3 days, mind you, you can do it full-time, but I was only part-time. So what I did do was I had about 6 to 7 patients that I managed their care. So when they come on to the hospice company, I'll I don't really do the admission visit. They already have an admission nurse, but they are my patients. So I come out and do the head to toe assessment. I see, what do they need? Do you want to continue medication? Do you want to, because mind you, just because you can still take some type of medication too. So people think that hospice, you can't do these things. You can. So you're going to go out and see what they need. As me being an RN case manager, I'm going to say, okay, what is it that you need? Do you need a volunteer? Do you need chucks? Do you need diapers? Do you need help in your home? Is there medications that you need? Is there do you need a home health aide? Do you need a volunteer? Do you need a chaplain? Because chaplains help too. They're not just there to pray for you. They're there as psychological support as well. So I go out and I do the initial assessment of their home, see what they need, see if they're able to ambulate, see what's their FAST score, see if they can ambulate, how far can they ambulate before getting tired and shortness of breath. Okay, do they have strength? Do they have weakness? Like, what are the things that this patient needs to keep them as comfortable as possible? Are they in pain at the time? Do they have chronic pain anywhere? Do they have acute pain sometimes? Like, what are their needs? Like, so for me being their case manager, I'm going to go out, see everything that they need. Are there, and then also I go every week. We have meetings, so it's the RN case manager, it's the LVN that goes out, it's the home health aide, the social worker, the chaplain, and the doctor, the physician. We all sit down, we all have IDT meetings every week. We discuss the patient. If the patient been on for a while, we say if this patient still, will tell the doctor our assessment of the patient. Do we think that they need to prolong? Do they need to continue hospice? Do you think that hospice is appropriate? Can we fix their medications? Can we offer them this? Can we offer them that? It's like we're managing their care. We're going to make sure that they are as comfortable as possible. We're going to make sure that they have everything that they need to make sure they're comfortable, as well as supporting their families too, because families need support too. We always think about the patient, but we don't actually think about the families as well. That's what I did as a hospice RN. Oh, and I also went out, say for instance, if they needed wound care, things like that. We did the wound care. If they had like say something just happened all of a sudden. Say for instance, it was like acute symptom that they had. The family noticed, oh my God, like they that the patient had a high temperature, struck a temperature, has shortness of breath that they don't normally have, is complaining, is whining, something is going on with them. The RN goes out to assess them, and we further we use our critical thinking to see if it's something that we can fix right then and there, or something that we can treat right then and there. If it's something that's over us that we can't really grasp what to do, we always coordinate with the doctors, as well as our RN case manager. In our RN period, when you doing that, you go out to the patient. If it's your patient, sometimes you may cover other people's patients. Say for instance, if they're imminent means that they're like in a dying stage, like you know that they're about to die within the next 24 hours to 3 days, like they're actively dying. Sometimes people are imminent for a short period of time. Sometimes it prolongs, you just never know. But if you notice some of these signs and symptoms that they are in imminent death, or they're dying, you are going out there more frequently, like every day, to see them versus once or twice a week. And then you're talking to the family about their end of life decisions. You're setting up the mortuary to come and pick up the body. You're assessing a patient. You're letting the family know about the patient. Okay, this patient is the dying process, what they're going to be experiencing. You're going to see that their breathing is going to be more like agonal breathing, and just all these different things. You're going to be discussing the dying process with the family to make them more comfortable. Sometimes they're not. You're there to support them. We did things like that. And then with palliative care, that was home health. So I would drive to my patient's house. With palliative care, I was in an outpatient setting. Oh, well, let me hurry up because the video is pretty long. I did not know it's going to go this long. But palliative care, the patient comes in, the doctor, the nurse, and the social worker, we all go in with the patient on every visit, and we're documenting for the patient. As the nurse, we have autonomy there, and it's also autonomy with home health as well. But palliative care, I have autonomy. I can go and discuss the patient's needs. If I feel like the patient's medication is incorrect or the patient is having more pain, the patient has Dilaudid, say for instance, every 4 hours has 1 milligram of Dilaudid pill every 4 hours, but their pain is not subsiding, I can suggest to the doctor, let's up their dosage to 2 milligrams of Dilaudid every 4 hours, and let's give them MS Cotton long acting every 12 hours. You know what I mean? Because that's what we do. We manage their care, and this is stuff that the nurses can suggest if we feel like with palliative care. Say for instance, the patient tells you, like I had a patient showed a picture, his leg was super swollen red. He said it was hot to touch. He said it was swollen, and the picture showed all the signs and symptoms. I said, okay, and it was only one leg. I said, okay, you need to go to urgent care just to make sure that you don't have a DVT, or make sure it's not cellulitis, things like that. And these are things that the nurses can do without the doctor because you have autonomy. So yeah, these are the two different types of nursing or jobs that you can do that's outside of bedside. I know I spent a lot of time on hospice, not too long on palliative care, but if you guys have any questions, you can let me know. I hope this was informative, and until next time.